we have a cameo appearance from Dr. Katia Pagnano from Brazil, who has brought a case to us today. Katia, would you like to introduce your case?
Yeah, thank you, Aline. So this is a case that I'm currently treating this patient. He's an old patient, 77 years old, diagnosed with CML in March 2020, intermediate SOCO and ELTS. And his only comorbidity is hypertension. He started imatinib 400 milligrams a day and achieved hematological response, but failed to achieve cytogenetic and molecular response. Then we switched the patient to dasatinib in November 2020, but he had a recurrent grade 4 thrombocytopenia. So we have to do some temporary interruption, dose reduction, and we, even with 20 milligrams a day, he only achieved hematological response, and then he lost the hematological response in March 2022. We looked for BCR-ABL mutations at this occasion. He had no BCR-ABL mutations. In Brazil, the third line is a problem. Sometimes we can get a third option. In this case, we could get nilotinib, and then we started in May 2002. But he had no toxicity, tolerated very well the full dose, and achieved hematological response. But he did not achieve a molecular response, and then lost again hematological response in January 2023. At this time, we didn't have ponatinib available. The patient's too old for going to transplantation, and we have to start hydroxyurea for hematologic control only. But then during the hydria treatment, he developed thrombocytopenia, then he had to stop medication, but the platelet counts maintained below 100. So we consider this patient as an accelerated phase by this criteria, because even after interruption, he did not recover the platelet counts. Fortunately, there was a compassionate program of asciminib, and then we could start asciminib 80 milligrams a day in March of this year. Then after 5 weeks, he had again grade 4 thrombocytopenia, and we have to interrupt the drug. About 3 or 4 weeks, he did not recover. Then we did a bone marrow aspirate to see if there was transformation to blast crisis. Fortunately not, he's not on transformation. This was done 1 week ago. Now the platelet counts raised above 25,000, which are for the guidelines for accelerated phase. So I would like to know which would be your approach in this case. Then I will tell you what I did. Okay. But he had no mutation. In all the times that he presented resistance, we looked for BCR-ABL mutations, but we were not able to find. And then I would like to hear from you if you would go to try to introduce 100 to 20 milligrams, or if you consider the guidelines, like for 80, reduced to 40, and then what would be how to manage this patient?
So I think the couple of questions, obviously, we're still waiting for some of the markers to come back, the cytogenetics and the PCR on the marrow, right? So if I think that's what I would think would be needed for us to decide which way to go. If the cytogenetics are negative, that means they are in complete cytogenetic response. I would wait before starting any therapy, especially with somebody his age. I think we can wait and see rather than pushing through with low counts and with the platelets being in the 20s, especially. I think I would be worried about pushing it any dose for now. If there is a lot of disease still remaining, then that's when I think we'll have to probably try to, with transfusion support or supportive care, push through. And there have been some publications from MD Anderson where they use Promacta or drugs like that. I don't know if those are possible or available to use, but if there is persistent disease, but if there is no disease, my preference would be to wait and see if the counts would come up. Kendra, what do you think?
I think, obviously thrombocytopenia is a well-documented side effect of asciminib, and it seems to be much more, and I guess this doesn't come as a surprise, but it seems to be much more common in patients who've had cytopenias from other drugs as well, right? It's at least in my experience, been a lot less common in the patients whose counts have been fine on every other drug beforehand. It's the patients who had cytopenias and couldn't tolerate the other drugs, and we try asciminib, and the same thing seems to happen. So what you're describing here with the thrombocytopenia, I've seen that in a few people, where it's just every drug just drops the platelets. And so I think at some point we have to just accept a lower platelet threshold, which is not a satisfying answer. But as an example, I have a patient who I've actually been treating now for 10 years. He's on dasatinib 20 milligrams 5 days a week, and his platelets kind of hover between 30 and 50,000, and his BCR-ABL is between like 15 and 35%. I mean, he has terrible control of his CML, and his counts are terrible, but we've been doing this for 10 years. So it's clearly doing something. But every drug we've tried has the same problem. And so we've kind of just reset ourselves and our comfort level with his counts. And because I don't know that there's a better alternative. Obviously, if you go by the prescribing information, and you have to be holding the drug, but his disease is going to progress if you do that. So I think as long as he's aware of risks associated with thrombocytopenia and the reasons for trying to, maybe not asciminib 80, but maybe 40, maybe that's, and just hoping to achieve some kind of CHR. But again, you've lost that with these other drugs in the past. So, I mean, this case is obviously a little tougher than the guy that I've had, but I think just accepting that his platelets are going to be lower than we're comfortable with may be something that we have to do.
Yes, I agree with you, Kendra. I'm trying to stay between 25 and 30. Now I try to reintroduce, and then later I will tell you what happened, because this is a very difficult case. And this man is funny. He likes to act judging the football games. So he runs. In 75 years old, he runs all the field in the football game.
Oh my gosh!
And I said, no, please. But he's feeling very well. So
Virginia, you have your hand up.
To keep above 30 at least. Thank you.
Yeah, I wanted to ask you, Kendra and Vamsi, would you try to combine this with the Thrombopac if you could for this patient? Have you done it, and what do your results have been in that? Because I had a patient like that exactly, and as you said, Kendra, I've been 10 years having her with 20 plus platelets and come and go, and I put her on a little bit of a Thrombocap, and she responded very, very well. Have you tried that? Will you do that?
Vamsi, you mentioned it earlier. I've never done it, but I know. Have you done it?
Yeah, we have done it actually. On the other end of the spectrum, I have somebody who you both have brought up. I have somebody who has severe neutropenia. So the only thing that she recovers with is disease. Possible reasons may be that the clone is the only hematopoietic component for that cell line. Like, let's say the platelets are essentially all coming from the CML clone. So when you suppress the CML, the clone dies off and there is no more platelet production. So when you stop treatment and the disease comes back, the platelets come back, because that's probably what is producing some of the platelets. And similarly, my patient had severe neutropenia, white cell count ANC, neutrophil count less than 200 as soon as you start treatment. When you stop treatment, she takes a month or two to recover the ANC, but she comes back with the disease always. So we have her on a once a week Nipogen, and it's been 14 years now that she's been on that. So there is always a theoretical risk, worry that drugs like Promacta and plate and those would it alter the disease course and would increase. That certainly, I think there are risks with both approaches. Leaving them with low platelets is acceptable, especially if they're stable there, then I think Kendra's plan looks great. But if it is somebody who is fluctuating, dropping below 20s and going up and dropping below 20s, then that's when I would consider using Promacta because of the risks with low platelets as well. Especially when you stop and it's only the disease that is coming back, then I think we are stuck with having to look at something outside the box.
Rafa has his hand up, but the audio is terrible. Shall we try one more time, Rafa?
Yes, I'll try. This is a question to take in account. This patient has thrombocytopenia for all the TKIs. So some of the high antihypertensive drugs may cause deep thrombocytopenia. Have you been explored this possibility?
I don't think I understood the question.
The antihypertensives can cause some thrombocytopenia. So I think he was asking, Katya, if this patient has what antihypertensives is he on, or is it something that you have considered looking at as the cause of some degree of thrombocytopenia?
Other causes, do you mean? Other causes for thrombocytopenia? No.
The
Yes.
antihypertensive medications that he's on for his blood pressure, I think.
No, I checked that. No, nothing that could interfere in platelet counts. I judged that the thrombocytopenia he had before starting asciminib was accelerated phase. There were no concomitant medication that could cause thrombocytopenia, and I also checked its serology, hepatitis and HIV and other things to exclude other causes. His liver is okay as well. So I only thought about the disease. I'm looking for the cytogenetic results to see if there is any clonal evolution. But still, I don't have still the result. It was done a week ago. This week, I reintroduced the medication 40 milligrams a day. And then I will see him next week. I don't know what is going to be the behavior. But I hope he can tolerate the lower dose.
That was reasonable to me.